Hello everyone, and welcome to our CLL Care webinar, Deeper Exploration of Cardiovascular Complications in CLL. My name is Bianca, and I'm really happy to have you here with us today, because today's session is actually very special, not only because of the important topic that we're going to cover, but also because we have two fantastic speakers joining us. So please let me introduce them to you. Leading today's webinar is Professor Clemens Wendtner, a very appreciated expert in CLL, currently serving as head of the Department of Hematology and Oncology at the Munich University Hospital in Germany. And we're really honored to have him with us today. On the other hand, we are also honored to welcome Dr. Maria Solandres, a cardiologist specialized in cardio-oncology from the Royal Brompton Hospital in London. And Dr. Andres will contribute to part of today's presentation, bringing valuable insight with her expertise on cardiovascular risk in patients with CLL. And before starting, I would just like to remind our audience that they will be muted for the entire duration of the webinar. And we are also encouraging you to write all your questions in our chat box, and we will be replying them at the end of the presentation. So, Professor Wendtner, Dr. Andres, please, the stage is yours.
Yes, thank you very much for the kind introduction, dear colleagues. So the topic is CLL, and especially cardiology side effects, which we all want to manage. So here are the objectives. You should understand the mechanism behind cardiovascular complications associated with CLL. After this seminar, you should be able to discuss risk factors related to both the disease and its treatments and patient profiles. And we would like to explore together with you the latest insights and strategies for managing cardiovascular complications altogether to improve patient outcome. This is clear. So what is the current approach to a modern state-of-the-art CLL treatment? It's mainly based on the use of so-called Bruton's tyrosine kinase inhibitors, BTKIs as we call them, and B-cell lymphoma 2 inhibitors, so BCL2Is, and their combinations. So you will see we will not talk much about chemotherapy or chemoimmunotherapy in the next 45 minutes. So the first group, as mentioned, the BTK, the Bruton's tyrosine kinase inhibitors. You see an overview. There are 4 candidates in Europe. All of them are approved. The same is true for the US market. You see ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. So ibrutinib we call a first-generation BTK inhibitor, acalabrutinib, zanubrutinib, a second-generation BTK inhibitor, and pirtobrutinib that was recently, with the 1st of April 2025, approved in Europe as a non-covalent BTK inhibitor. But you see in red, all these BTK inhibitors have a so-called class effect with respect to their side effects. So hypertension, cardiac arrhythmias you see for all of them. And this is the reason why I would like to discuss this in more detail together with you today. If you have a look at the current ESMO guidelines for CLL, for first-line use of drugs, you will not see, major restrictions for patients with cardiac comorbidities in their use. There are some comments on the side effects, and that in the one or the other group, the use is cautioned. But in the end, these drugs can also be used in patients with cardiac comorbidities, but you have to know how to use them safely. This is true for the frontline setting, and this is also true for patients in the relapse setting. You see this also from the ESMO guidelines. Again, acalabrutinib, ibrutinib, even the pirtobrutinib. You see here the non-covalent BTK inhibitors are mentioned in this guideline, and also zanubrutinib. And there is a clear sentence saying that ibrutinib should be considered carefully, particularly in older patients with cardiac comorbidities. Now, let's also have a transatlantic look. So the NCCN guidelines 2025 that are used in the US and in the Canadian market, not much different. Again, BTK inhibitors, venetoclax-based therapies are firmly recommended in the frontline setting. What is shown here in yellow just tells you that FCR and other things like high-dose steroids are not the primary choice for our patients with CLL. Having said this, the same is true for high-risk patients with a deletion 17p or TP53 mutation. Again, this is the scenario usually for the use of BTK inhibitors. And also here, venetoclax combos like venetoclax-obi, obinutuzumab is recommended by the NCCN guidelines for patients with a TP53 aberration. Chemoimmunotherapy like bendamustine rituximab should not be primarily used for these kind of high-risk patients. The same is also shown here. Patients with a deletion 17p, you see all the algorithms also for patients with a relapse disease. There we are talking about even CAR T-cell use. This is Lysocell is approved in the United States by the FDA. It's not approved in Europe. But for example, pirtobrutinib would also be a reasonable choice for patients that do not respond anymore to a first or second generation BTK inhibitor and harboring a high-risk aberration like TP53 mutation or deletion. Now, in general, we are considering patients for a continuous monotherapy with a BTK inhibitor, or for a low or intermediate risk patient, we also consider fixed duration combos like BCL2 inhibitor plus and CD20 antibodies. So this means the frontline setting, venetoclax obinutuzumab. The other choice in Europe would be BTK inhibitor ibrutinib plus BCL2 inhibitor venetoclax, so-called I+V regimen. And I would say only in very rare selected cases, you might even think about chemoimmunotherapy, but this is otherwise a little bit out of age, out of range. In summary, I think BTK inhibitors and BCL2 inhibitors are real game changers in the CLL treatment. We have multiple phase 3 trials that have established their role. We have understood the mode of action for these components. They are interacting in the B-cell receptor pathway and the BCL2 pathways. We have data that they even have a major impact on survival, not only on progression-free survival, but also overall survival in CLL patients. Now, let's briefly talk about the mechanism of action or the mode of action for these two groups of drugs. So the BTK inhibitors, you see they inhibit the Bruton's tyrosine kinase. And so they are preventing autophosphorylation, blocking the B-cell receptor signaling. That's very crucial for a B-cell function, also for malignant B-cell function. And what is also very important, they lower the CXCR4 expression. And so CLL cells are liberating from the lymph nodes, from the bone marrow in the peripheral blood. And they are available also for other drugs like a venetoclax, a BCL2 inhibitor. They reduce the MCL1 protein expression, and so it's a pro-apoptotic mechanism. And so a CLL cell becomes more reliant on BCL2 signaling. And here I would give the stage to my colleague, Dr. Andres.
Thank you, Professor Wendtner. So before we start discussing and trying to understand what are the cardiovascular events associated with the treatments that Professor Wendtner has very clearly described, let's briefly explore what's the prevalence of some of the most frequent cardiovascular events in the general population. So when we talk about hypertension, hypertension is the leading preventable risk factor for cardiovascular disease and all-cause mortality worldwide. More than 31% of the global adult population have hypertension, and this can go even higher in cancer patients, up to around 40%. And it's very important because this is a silent disease. And why is this prevalence even higher in patients with cancer? Well, this is because blood pressure levels and hypertension prevalence increase with age, with kidney disease, with smoking, diabetes, obesity, and we all know that these are shared risk factors between cancer and cardiovascular disease. And obviously the elephant in the room, cancer treatments such as BTKIs can increase the risk of hypertension. Atrial fibrillation is the most frequent cardiac arrhythmia. The prevalence in general population is between 1.5 and 2%, but it can go up to 30% in patients with cancer if we consider atrial fibrillation after surgery. As you can see from the graph here, atrial fibrillation is age associated. So the older the patient, the higher the risk of atrial fibrillation. And this is also important because we know that CLL and these malignant hematology diseases are associated with age as well. The age group of more than 65 years makes up to 73% of global absolute atrial fibrillation and atrial flutter prevalence. And why is this so important? Because atrial fibrillation is a major risk for ischemic stroke and heart failure. And it can also be a silent disease as it is with hypertension. So back to you, Professor Wendtner.
So thank you, Dr. Andres. So I will take over here and just briefly discuss from an oncology perspective why cardiovascular events are so important to understand them. I think that you have to know that these drugs I mentioned, the BTK inhibitors, they can act as a kind of trigger that might precipitate cardiovascular events. And we do see some differences. So altogether, it can be said that in patients that are treated with ibrutinib, these cardiovascular events might occur earlier than for a second-generation BTK inhibitor like acalabrutinib or zanubrutinib. But you then have to expect further events in the future. So we know that with the so-called first-generation BTK inhibitor, this is ibrutinib, we have a significant increase in cardiac events. So this is hypertension, as just heard. But this is also ventricular fibrillation arrhythmia, AFib, so atrial fibrillation, could also be a sudden heart death, and CHF, so congestive heart failure. We also know there are some bleeding disorders, but this is usually due to blocking the glycoprotein 1b and 6 with BTK inhibitors. But we will focus now on cardiac events. And this is the reason why we do have a high discontinuation rate, up to 40% in the first 2 years when patients are treated with ibrutinib. As you can see here, this is also a thing we have to discuss whether, the second generation is safer with this respect. Just as a comparison, 1/3 of CLL patients treated with ibrutinib develop atrial fibrillation within 2 years. we know from the second generation acalabrutinib and zanubrutinib BTK inhibitors that these events are less. We also know that bleeding events are comparable with ibrutinib. This has to be fairly sad, but especially cardiac events seem to be less with the second generation BTK inhibitors. In general, we have to consider that despite the fact a patient develops hypertension, this is not an absolute contraindication to use a BTK inhibitor. It's just a matter of good management together with the cardiologist. That's the reason why Dr. Andres is also here today. We do consider, nevertheless, a patient that develops or has a history of serious ventricular arrhythmias should not be exposed to ibrutinib. At this point, we don't know the real value of second generation BTK inhibitors like acalabrutinib, zanubrutinib. My personal recommendation would be, if there is a serious ventricular arrhythmias history, there are other options than BTK inhibitors. We also know BCL2 inhibitors. But this is still an open issue. Serious ventricular arrhythmia is a contraindication for ibrutinib. That's the bottom line. So we know if there is a FIP, we also have to calculate the so-called JETS-VAS score. We know that a patient has to receive an anticoagulation. We don't like warfarin very much in this situation. It's more a case for DOACs. They might even be dose reduced. With the development of emerging hypertension, first you should ask your patient to do also blood pressure monitoring on a regular basis at home. And we have a lot of medication we can offer to the patient. We should always look whether there is a drug-drug interaction based on CYP3A4 inhibition. We should use non-ACE inhibitors in the first run as a treatment for hypertension. But there might also be patients that are in need for combo treatments in order to really control, especially systolic blood pressure. In a case with emerging heart failure, this is usually a combo treatment, ACE inhibitor, for example, plus a beta blocker. This is usually a way to treat these patients. But you have to really follow up these patients. Assessment of ejection fraction, for example, every 6 to 12 months is a standard in these patients. Now, let's briefly talk also about BCL2 inhibitors. So the first class drug is venetoclax. There might be second generation BCL2 inhibitors, but not approved at this point. So venetoclax is a pill. The target dose is 400 milligram. You're starting with 20 milligram. There's a ramp up over 5 weeks so that you get 20, 50, 100, 200, 400 milligram to the target dose. You see adverse effects are less cardiac effects. We are talking about neutropenia here, thrombocytopenia, anemia, fatigue. So this is the usually safety profile of this class of drugs. They have a different mode of action. This you can see here. So the BCL2 inhibitor directly targets the BCL2 protein and enables, to put it in simple words, the CLL cell to die. So programmed cell death is reinstalled. And the nice thing is you can combine these drugs with the BTK inhibitor. So as mentioned before, you're liberating the CLL cell from the lymph nodes by decreasing CXCR4 expression. then the CLL cell is in the peripheral blood, and then you kill it with a BCL2 inhibitor. That's the mechanism we are making use of. Going back to the BTK inhibitors, this is just a summary of clinical trials, mainly phase 3 trials using ibrutinib. And you can see AFib, hypertension, ventricular arrhythmias. So I'm focusing on grade 3, 4, 5 side effects. You can see there are side effects with these drugs. So AFib, if you just look at the percentage, 5-6%, grade 3 and 4 hypertension. This is even much higher. You see 29, 34% in some trials of patients develops a serious hypertensive side effects. Ventricular arrhythmia, fortunately, is not as high. You see some 1-2% side effects, but you have to watch out for the side effect. This is the list for acalabrutinib and sonobrutinib, so the second generation BTK inhibitors. If you compare grade 3, 4 events, you might just get this from this curve, from this figure, that in this table we have less percentages, so a lower frequency of these kind of side effects, so less hypertensive events, less AFib, and also ventricular arrhythmias almost do not occur with the second generation BTK inhibitors. Just to zoom in one big trial, this is the so-called ELEVATE-TN or treatment-naive CLL trial using acalabrutinib and also the acala plus obi. This is A plus O or A mono. And you can see here in detail a AFib rate, grade 3, 4, 1.7%. Hypertensive grade 3, 4 events, 4.5%. So very low rates. This is the reason why if you decide for a monotherapy nowadays, and you want to use a BTK inhibitor, I usually go for a second generation BTK inhibitor, so acalabrutinib or sonobrutinib. Now, this is a figure. This might be also very impressive. You see AFib in this trial, the so-called ELEVATE-RR trial. You see that here the rate for AFib and hypertension is lower. This is the blue line, the lower line compared to ibrutinib. So there is a head-to-head comparison to ibrutinib, and in both, or with respect to both categories, the side effects were lower for acalabrutinib. Taking things together, I think patients on the second generation BTK inhibitor acalabrutinib experience fewer cases of AFib, aflutter, hypertensive events, and also bleeding events I didn't mention compared to ibrutinib. This is, I think, a real hallmark in CLL treatment. This is just another way to show these impressive data, also based on the ELEVATE-RR trial, how side effects are lower with respect to AFib and hypertensive events. So why is this the case? Because acalabrutinib is more specific. We have less off-target inhibitions by the second generation BTK inhibitors. We also know that the disruption of PI3 kinase ACT pathway is less, and therefore also the frequency of CHF based on acalabrutinib treated patients is very low. It's only 1%, and this argues again for the use of second generation BTK inhibitors in the CLL setting. Also, the hypertensive events are shown here. Altogether, without going too much into details, we have less hypertensive events when using acalabrutinib, but you see with ibrutinib, we have this problem also years after start of treatment. It's not a short event in the first weeks or months, but you see that also the problem with hypertensive disease is a long-term problem when using a first generation, let's say an old-fashioned BTK inhibitor. So the long-term outcome with CLL patients treated with ibrutinib can be summarized that you really have to watch out for hypertension, and then also many patients develop new onset hypertension. That's a little bit worrisome. It's not only the aggravation of hypertensive disease that has been there before, but it's also a new onset hypertension that patients might develop on ibrutinib. Again, the off-targets effect are important, and they is especially the PI3 kinase pathway interaction, and this might lead to myocardial dysfunction and hypertension. We also know that, for example, ibrutinib has a very strong inhibition of the P-glycoprotein, and this enhances also effects of direct thrombin inhibitors. Also not very wishful for a patient that needs these kind of medications. Therefore, there is also the recommendation that if you have to reduce drug-drug interaction, it's recommended to switch patients with AFib that are taking, for example, verapamil to beta blocker when starting a BTK inhibitor, because there is less interaction with these kind of proteins. Now, the possible mechanism of BTK-induced arrhythmia, we know the role of the C-terminal SAC kinase, the CSK, but there are also some other proteins that may play a role in the AFib development. But the CSK, there are also mice models, for example, that have shown this impressively. We know that the calcium calmodulin dependent protein kinase 2, the CMK2, is also important in the development of BTK-induced arrhythmia. And all these interactions are less with second-generation BTK inhibitors. And this is the reason why also from a clinical point of view, the second-generation BTK inhibitors have a better safety profile. So finally, the relation between the atrial fibrillation burden, occurrence of major adverse cardiovascular events, and mortality. To make a long story short, we can say that based on a retrospective study, that patients that were treated with ibrutinib, that this subgroup of patients that developed AFib, they also had lower progression-free survival. So that's also from an oncology perspective setback, and they have also inferior overall survival. It's not only a PFS story, but it's unfortunately also impacts overall survival because they have a threefold increase in long-term mortality. So the pathophysiology of AFib in cancer, you see that this is not only associated to the drugs, it's also a matter of aging. It can be also a matter of invasion of cancer cells, also in the heart muscle and things like this. It's a story of inflammation that also might trigger AFib events. So we have these kind of MACE studies. You see that nearly 20% of patients with new or worsening hypertension are documented when using these kind of drugs, but it's less with the second generation BTK inhibitors. So hypertension may increase also the risk of further. It's not only the only problem, but hypertension is, I would say, the door opener for other cardiovascular events during the BTK inhibitor therapy. As told, AFib can develop when a patient develops hypertension first, but also MACE can develop in these patients. So we have also some calculations of predictors of MACE during acalabrutinib, so second generation BTK inhibitors. We know that age is a risk factor, and prior AFib or flutter is a risk factor. At this point, I would like to give back the stage to the cardiologist here in the room.
Thank you very much. So we'll now try to analyze or discuss the different approaches to mitigating the cardiovascular risk in patients with CLL. So the first step in order to, and a very crucial step in order to reduce the risk of cardiotoxicity with any potentially cardiotoxic drug is to do a proper baseline risk assessment. This is a clear basically to understand what our patient looks like. And an easy way to do it is to calculate the risk with the HFA-ICOS risk score, which has been published in 2020 in the European Heart Journal. And it was a joint effort between the International Cardio-Oncology Society and the Heart Failure Association. And this document presents 7 baseline risk performers for different groups of drugs. So it's not a specific one for BTKIs, but we can use the one for BET inhibitors or BCR, ABL TKIs. But mainly what I want to highlight here is that the risk of cardiotoxicity includes the history of previous cardiovascular disease of the patient, the history of previous cardiotoxic cancer treatment, the demographic and cardiovascular risk factors, and the lifestyle risk factors. And we can calculate the risk by doing this manually or very easily with downloading the ESC Pocket Guidance app where the scores are embedded. So this baseline risk assessment will help us determine how the patient should be monitored during treatment and if the patient can start the treatment right away. The general approach is that if a patient is considered low risk based on this assessment, then the patient should not have any further delays, any further cardiovascular assessment, and start treatment right away. Now, if the patient is considered high or very high risk, the patient will definitely benefit from an assessment by a cardiologist or a cardiologist, a discussion between professionals of what is the benefits and the risks of using different types of drugs and adjustment of cardiovascular medication prior to cancer treatment. All cancer patients should have an assessment of their cardiovascular risk factors, cardiovascular disease history, cancer history, and cancer treatment history. But also, it is a recommendation class 1 from the ESC Cardio-Oncology Guidance published in 2022 that all patients have an ECG at baseline, and especially if the patient are going to be started on a BTKI, where we know that atrial fibrillation is a very frequent side effect. Also physical examination, including blood pressure measurement at baseline. And if the patient has a pre-existing cardiovascular disease, or in the case of our patients, our BTKI patients, where if the patient is considered high risk or very high risk just by having a history of high blood pressure, a history of atrial fibrillation, then it is also recommended to do a baseline echocardiogram. So ECG, blood pressure measurement, cardiovascular history, and risk factors assessment. And if the patient has history of hypertension, history of AF, or of cardiovascular disease, then an echocardiogram at baseline as well. What about how do we monitor cardiovascular risks during the treatment? Sorry, cardiovascular events during the treatment. So now the patient is already on the BTKI. We know that the most frequent side effects from a cardiovascular point of view are atrial fibrillation, hypertension, and heart failure. And in a lesser frequency if the patient is on a second generation BTKI, but the way of monitoring or identifying these problems during the treatment, which, as I said at the beginning, they have the particularity of they can be silent. For blood pressure, their only recommendation, class 1, is to check the blood pressure at every clinic visit. So if the patient comes to you for treatment or for a clinical assessment at the hematology clinic, then to check the blood pressure there. Weekly home monitoring of blood pressure during the first 3 months and every month thereafter can be considered. This is a 2A class recommendation, but a level of evidence C. In terms of the echocardiography follow-up, as I said before, at baseline for patients are considered at high risk or have cardiovascular risk factors such as hypertension or underlying atrial fibrillation, but also during treatment, if the patient develops new onset atrial fibrillation, that's a class 1C recommendation. So, and I would add that if the patient develops new onset hypertension or any new cardiac symptoms such as palpitations, chest pain, or shortness of breath, then an echocardiogram should be the first step in the investigation of what's going on with the patient. In terms of how to identify atrial fibrillation during treatment with BTKIs. So the only recommendation is to do opportunistic screening of AF by pulse taking or ECG rhythm strip, meaning that when the patient comes to see you, you check the pulse. If the pulse is irregular, then proceed to doing an ECG. Or if you're not sure or you don't trust your ability to check the pulse, then just arrange to have an ECG done every time the patient comes and see you. There is no recommendations in terms of having patients doing a 24-hour Holter monitor regularly because of the characteristics of the nature of atrial fibrillation, which can be paroxysmal, and the fact that it is not found on a Holter monitor doesn't rule it out. And so that's the only recommendation. However, is there a role for wearable devices? We are now in the era of wearable devices, of AI, of technology, and patients are already using them. And you're now getting more and more these questions by the patients. Should I buy a smartwatch to check my rhythm? Should I get one of these new devices like the CardioMobile, where they can put the fingers on the device when they have the symptoms of palpitations? Or even should they get a more modern device such as the Actia models, that's the bracelet, the black bracelet that you can see in that figure there, that checks regularly. Actually, it's a continuous control of the blood pressure and the rhythm. Well, there is enough evidence already to say that these devices are not recommended in the general population because of the high risk of false positives. However, in a population such as patients who are on BTKI, where we know that they're at very high risk of developing AF and hypertension, there could be a role. Of course, there's still not enough evidence to recommend against or for, but there are ongoing trials that maybe can give us some promising results in the future. So we talked about baseline risk assessment of the patient, monitoring of the patient during treatment. Now let's discuss on how to manage the patients once they develop the side effect. So atrial fibrillation. Atrial fibrillation, which is an arrhythmia, which is obviously generated in the atria. When a patient develops this arrhythmia, for us cardiologists, there is very little difference in the management in terms of cancer patients and non-cancer patients. In terms of the rhythm, if the patient is unstable hemodynamically, then the patient, and by this I mean the blood pressure has dropped, or they have signs or symptoms of heart failure or continuous chest pain, the patient needs to be admitted into CCU. Treatment with ibrutinib, acalabrutinib, or zanubrutinib should be interrupted whilst the patient is unstable. And the recommended treatment by any arrhythmia guidelines is to revert the rhythm back to sinus rhythm by electrical cardioversion or medical cardioversion. That will depend on each case. Now, most of our patients, most of the ibrutinib-induced AF patients won't be these cases, won't present as unstable symptomatic patients. They will present as stable, asymptomatic, or maybe with some mild palpitations. And so the treatment here is completely different. We can treat them as outpatients. We don't need to interrupt treatment with ibrutinib or the BTKI they are on immediately. They can continue on them, but we need to focus our management on rate control, meaning that we won't try to go into reverting to sinus rhythm, but actually to reduce the rate with mainly a beta blocker. Now, atrial fibrillation has two main parts of the treatment. One is rate or rhythm control, which we just discussed. The second one is anticoagulation to reduce the risk of stroke. And as Professor Wendtner just said something about it before, when discussing anticoagulation in cancer patients, and especially in patients with BTKI, it is imperative to assess the thromboembolic risk versus the bleeding risk. The strategy recommended by the ESC cardio-oncology guidelines is the TVIP strategies. T stands for assess thromboembolic risk, and the CHADS-VASC, actually now it's turned to the CHADS-VA because the female component has been taken out of the score, is the recommended way of assessing the thromboembolic risk. And if it's above 1, then anticoagulation should be considered. B, for bleeding risk. In this particular group of patients, we know that their bleeding risk is already elevated because of the effect of the BTKI on the platelet function. So this it puts us in a conundrum. It decreases the risk of bleeding, it increases the risk of AF. I for drug-drug interaction, and P for patient's preference. Long story short, the drug that we preferred are the NOACs. They have a better, less variability in the anticoagulation state. They have less risk of bleeding, and but there are some cases, such as patients with prosthetic valves, where these are contraindicated. Well, then we would have to think about either a VKA or a low molecular weight heparin. Let's move on to the treatment of hypertension. Treatment of hypertension in cancer patients and in CLL patients will be determined by the prognosis of the patient. If the patient is a patient with a curable cancer during treatment, or a chronic kind of treatment such as BTKI, we will treat them as we usually treat the general population. And the first line of treatment recommended are ACE inhibitors or ARBs, and this is because ACE or ARBs, so ramipril, enalapril, lisinopril, or candesartan, losartan, irbesartan, these drugs are also cardioprotective. They protect the myocardium, and we know that most of the cardiotoxic drugs are not, such as BTKIs, not only increase the risk of specific side effects such as atrial fibrillation, but they can also increase the risk of heart failure. If the patient has a very severe hypertension, then combined treatment is recommended. In the general cancer population, the combination recommended is usually ACE inhibitors plus calcium channel blockers. It is my personal recommendation also in this group of patients, so BTKI inhibitors, drug-induced hypertension, to consider the combination of ACE or ARBs plus a beta blocker, because we know that beta blockers can reduce the risk of atrial fibrillation. So, but there's two drugs that we should not consider, or we should consider avoiding, which are the thiazide and verapamil. These are the non-pyrimidine calcium channel blockers, and this is because of the drug-drug interaction. And actually, we don't usually use them for blood pressure control. So, if these patients are on these drugs for any other reason, such as Professor Wendtner just said, we should switch them to another treatment. Beta blocker if they are using it for IF control, or an ACE inhibitors or an ARB if they are using it for blood pressure control. When should we consider withholding the treatment with ibrutinib or acalabrutinib or zanubrutinib? We always try not to stop any potentially life-saving treatment. So but obviously there is a safety threshold, and the recommended safety threshold is when the patient presents with a blood pressure above 180 over 110, then consider withholding the cancer treatment. Start blood pressure medication immediately, and once the blood pressure has gone back to normal, or at least it's consistently below 160, then we can reconsider restarting the cancer treatment, and maybe at a reduced dose if that's appropriate. This is when the interaction between the cardiologist and the hematologist is crucial. So, as a summary of how to treat these two events in terms of the emerging atrial fibrillation, manage care using an MDT. If there are any cardiologists in the audience, try not to define what to do with a patient's cancer treatment on your own. You should never do that. And for hematologists and oncologists in the audience, just know that there should be a cardiologist there that could help you with the management, so as to reduce the interruption of the cancer treatment as much as possible. Professor Wendtner just mentioned that 40% of these patients need to interrupt their treatments at some point, and we know that that might have a negative impact on their overall health. So this is why it's so important to manage this as an MDT, as a multidisciplinary team. In terms of the treatment continuity of BTKIs, BTKI can be continued if a patient has asymptomatic or stable, hemodynamically stable AF. Warfarin is less preferred. And if a patient has persistent AF and this is causing some problems, then consider a second generation BTKI, and also consider dose reduction if it's appropriate. In terms of the management of hypertension, I've already mentioned how to monitor the patient's blood pressure, but if you're going to recommend blood pressure monitor at home, the patient needs to be educated on how to do it. Management with an MDT as well. We should avoid thiazide and verapamil because of the drug-drug interactions. And we, when thinking about combination therapy, why not using a combination with a beta blocker if it's efficient for blood pressure management. So yes, a specialist cardiovascular assessment is recommended for optimal diagnostic workup and management of patients with cancer who present with cardiovascular toxicity. So this is what I was talking about. The interaction between the oncologist, hematologist, and cardiologist is so important in this group of patients. And this is because balancing the risk of the disease progression against the potential to mitigate adverse events and enhance the patient's well-being is our ultimate goal. It's not just about communication between the oncologist, the hematologist, and the cardiologist. It's also about communication with the patient. It can be very scary for a patient that has a hematological malignant disease, and to be told that now they've developed a problem with their heart, and that they might have to interrupt the cancer treatment. So it's our role to explain what's going on to the patient with appropriate language, to create ways of communication, and also to educate on the appropriate lifestyle modification, on recognition of early signs of cardiovascular disease, and explaining why it's important to not to stop cardioprotective therapy without medical advice, but mainly to let them know that we are not here to be an obstacle between their treatment and their potentially life-saving therapy, but on the contrary, we are here to allow and make it possible for them to safely go through that treatment. So now I'm going to pass on to you again, Professor Wendtner.
Yes, thanks a lot, Dr. Andres. So we have heard now a lot of the hypertensive side effects, atrial fibrillation, and finally some words to BTK-associated heart failure. So this is the understanding that also the disruption of the PI3 kinase ACT pathway is responsible for this significant side effect. And it's also linked to AFib, but can also be further triggered by stress might also lead to heart failure. What is an important take-home message is that although there are not many long-term data, altogether we can say that a second-generation BTK inhibitor like acalabrutinib is quite robust with respect to the data we know about development of heart failure. So based on 760 patients, the incidence of heart failure is less than 1% of patients that are really developing symptomatic congestive heart failure. And this compares to another figure I'll show you in the next slide. And this is based on heart failure in ibrutinib treated CLL patients. So the rate of heart failure is much higher, 7.7% after 3 years, more or less. And this is even worse or higher, the frequency compared to the control group that has been treated by chemoimmunotherapy. So it seems that especially ibrutinib has some probability that a patient on the long run might develop heart failure, congestive heart failure. And again, this side effect is significantly lower in second-generation BTK inhibitors. So with respect to the management and treatment, I'm passing over again to Dr. Andres, please.
Thank you. So as we mentioned before, baseline assessment is very important in these patients. And if the patient has a history of or suspicion of heart failure, then it's not just the baseline risk assessment with the cardiovascular risk assessment and the ECG, but also a baseline echocardiogram is crucial. There is no established left ventricular ejection fraction threshold to contraindicate a BTKI therapy due to exclusion of cancer patients in most trials. However, if a patient has a very low ejection fraction, let's say 30% ejection fraction, or the patient is unstable, has symptoms of heart failure, then we might consider a non-BTKI treatment or a second-generation BTKI inhibitor to reduce the risk of AF or uncontrolled hypertension that can contribute to worsening of heart failure. So the only thing to consider when using BCL2 antagonists, which are very safe from a cardiovascular point of view, is that therapy may need aggressive intravenous fluids to manage tumor lysis syndrome, and this can worsen heart failure. So my recommendation is basically, if a patient has a history of heart failure, then before starting any therapy that has been agreed, be it a second-generation BTKI or BCL2 antagonist, the patient needs to be reviewed by the cardiologist in order to optimize the medical therapy, stabilize the patient as much as possible, and if possible, even put him in contact with a heart failure nurse. Now, what happens if a patient develops decompensated heart failure during the treatment? So as we talked about the patients who developed hemodynamically unstable AF or severe hypertension, in this case, if the patient has decompensated heart failure, we will need to consider temporarily interrupting BTKI treatment, referring to a cardiology as soon as possible, and assess for new atrial fibrillation or hypertension that can worsen or could have been the trigger of worsening heart failure. And obviously, the natural next step is to start heart failure treatment promptly. Heart failure treatment is based on 4 groups of drugs. These are the 4 pillars of heart failure treatment, which includes beta blockers, ARNIs, or aldosterone antagonist and SGLT2 inhibitors. And maybe the first step before an ARNI would be an ACE inhibitor. And the only issue with heart failure treatment is that we don't start all the therapies all together, same dose at the same time, because that might not be tolerated with the patient. So we usually start them with 1 tablet at a low dose, so let's say a beta blocker, bisoprolol 1.25 plus ramipril 2.5, and then we have to build it up from there depending on the tolerability of the patient. So, and this is what we call the up titration of the medication, and this can take some time, but we usually don't have this time with cancer patients. So what we strongly recommend is to have a team of hematology, oncology, cardiology, and nurse specialists, cardiology nurse specialists, who will help you optimize the medical treatment as fast as possible. And then, once the patient is stable again, consider restarting the cancer therapy. Maybe consider dose reduction at the beginning, or consider a second-generation BTKI. But consider all of this in an MDT scenario. In terms of the risk mitigation and management strategies, we mentioned most of them up to now, but what I want to highlight is that one way of preventing cardiotoxicity, obviously, is to limit or reduce the use of therapies that may harm the heart. But we would only do this if proven alternatives are available that do not negatively impact cancer-specific outcomes. So we don't want to prevent patients from receiving potentially life-saving drugs because there is a risk of cardiotoxicity. Actually, we can, as I mentioned before, there's lots of things that we can do to mitigate that risk and allow the patient to receive these potentially life-saving therapies. And this is the end of the presentation, a summary of how to diagnose and treat each of the 3 main side effects of hypertension, arrhythmias, and heart failure. I've talked a lot about all of this. I just want to mention one thing about ventricular arrhythmias, which we didn't touch upon too much. Ventricular arrhythmias are very rare, but may be a very serious side effect. If a patient has a history of ventricular arrhythmias, of serious ventricular arrhythmias, then it might be good to consider not using a BTKI if there is an appropriate alternative. Also, if the patient develops a ventricular arrhythmia, such as VT or VF, then obviously holding the BTKI and considering ischemia and heart failure evaluation and doing an MRI to assess the presence of fibrosis, because this will determine the prognosis. So this is all for today. I hope this was helpful, and we are open to receiving and answering your questions.
Yes, thank you very much for this amazing presentation. And it was actually a pleasure to learn from both the hematological and the oncology perspective. We have time for some quick questions. So I will start with the discussion, very, as I said, short discussion. We have one question regarding the impact of atrial fibrillation on hospitalization outcomes for patients with CLL. What is the impact of atrial fibrillation on the hospitalization outcomes?
So from a cardiovascular point of view, AF it has a negative impact in all the outcomes of the patients. It reduces the survival and worsens the prognosis of patients with CLL. So that's why it's so important to have a joint management between hematology and cardiology in order to reduce this negative impact on the patient.
Mm-hmm. And we have also another question, again, regarding the atrial fibrillation. So if a patient with atrial fibrillation is scheduled for surgery, should his CLL treatment, BTKI, be withheld, and for how long?
That's a really good question, and probably Professor Wendtner, as a hematologist, might be able to also help. In terms of the recommendation that we have from the ESC guidelines, BTKIs should be stopped 2 or 3 days before any surgical intervention because of the impact of its impact on the platelet function, and we usually stop the NOACs around 72 hours before a surgery. But if the patient has a high risk of stroke, we can bridge it with low molecular weight heparin. But please, Professor Wendtner, same media.
No, I totally agree. I mean, we have measured these. It's a so-called the resuscitation time. At least 3 days before surgery. Major surgery means 6 to 7 days before surgery, you should stop in order not to get the patient in trouble with bleeding. And important also, the surgeon should have platelet transfusions in the backhand in order to dilute the platelets. So platelets from healthy donor do not contain, we should assume, a BTK inhibitor. So even if the patient has a normal platelet count, the patient might have a bleeding due to the inhibition of the glycoprotein 1b and 6. This means you have to give this patient then in the surgery room with a normal platelet count, also platelet transfusion. So this is should be stressed.
So thank you very much. I think we are running out of time. However, let me thank you both again, Professor Wendtner and Dr. Andres, for this amazing presentation. And I also want to remind the audience that if they would like to revisit the content, the recording of the webinar is going to be available on our virtual platform soon, together with the post-meeting survey that we'd appreciate if they can take. So thank you once again, and we look forward to seeing you at our next webinar.
Thank
So
you.
have a great day.
Thank you very much for the invitation.
Bye-bye.
See you.
See you. Thank you.